So good day, friends. This is Dr. Bob Hamilton, and you have tuned in today to the Hamilton Review, where kids and culture collide. Thank you for making us part of your day. I appreciate it. It means a lot to me. I know that you're all busy people out there, and the fact that you're listening today means a lot to me. So thank you for that. And also, if you like what you hear, I am building an audience, and I want to get as many people as I possibly can to hear the guests that I have on my show, because without any kind of any outliers, the people I have had on my show are phenomenal, and today is literally no exception. Is such a pleasure today to welcome to the Hamilton Review Yvonne Bohn, Dr. Yvonne Bohn. She's a practicing obstetrician gynecologist in Santa Monica. She's also an author. She wrote a book entitled Mommy Doc's Ultimate Guide to Pregnancy and Birth. I'll say that again. Mommy Doc's Ultimate Guide to Pregnancy and Birth. She was also a host on a Discovery Health Channel series, which was called Deliver Me, 5 seasons. And so she's no foreigner to the screen and media. So it's a pleasure, Yvonne Bohn, to welcome you to the Hamilton Review.
Thank you, Bob. Dr. Bob. Hi.
Bob works. That works fine. So listen, Dr. Bohn, I like to have my guests introduce himself a little bit to my listeners. And so I'm going to turn the microphone over to you and tell us a little bit about your story, the points, the inflection points along that journey that ultimately caused you to be who you are today. So Dr. Yvonne Bohn, you're on.
Thank you very much for having me. So as you said, I am a practicing OBGYN in Santa Monica, California, and I am starting my 24th year in private practice this year. So 4 years before that residency. So 28 years of practicing OBGYN, which I can't even believe it's been that long, because it seems like it's been just a minute. And it's hard to really even start how I got here. But I grew up kind of living all over the country. My father worked for the Veterans Administration, so we moved every couple years. I finally landed in California. I went to UCLA, where I studied psychobiology. I met my husband while I was a third year in college. And we've been together ever since. I did my medical school at USC and my residency at the Women's Hospital at County USC. And it was during my training in medical school that I really discovered that I loved procedures and I loved surgical practice. But what I found at the time was that it was still very male dominated. So the surgical fields like general surgery, I loved neurosurgery, were very male dominated. And then I discovered OBGYN, where we got to do women's health, we got to deliver babies, we got to perform surgery, and we had a lot more women in the field training us. So it was a very comfortable place to be. And that's how I ended up in the practice of OBGYN. Over the last almost 30 years, I've made so many amazing relationships with my patients. I've been in situations with them which are dire, cancer, pregnancy loss, near-death experiences from hemorrhage. So it's a very emotional and physical and demanding field, because we really have, over the past 24 years, I have always tried to deliver my babies. So I really know patients for a long period of time. I have patients that I take care of generations. I have grandmothers, mothers, their daughters, and their babies. So I have 4-generation families now that I've been taking care of. I have mothers that bring their daughters who are teens or, early young women coming to see me. So it's an amazing field where you can really do a whole lifespan of a woman and help her. So that's kind of how I got there. And I love it. It's exhausting. It's crazy. It's incredible. I don't know what else to say about it.
No, I think that OBGYN, I don't know if you know this, Yvonne, I don't know if I've ever shared this with you. By the way, just one thing to everybody listening. Dr. Bohn and I are friends. We know each other from the hospital. We see each other very frequently over there. And so I should probably call you Dr. Yvonne.
Right,
But
Dr. Yvonne.
if you don't mind, I'll do my best. But anyway, the reality is that when I did my medical school as well, I was very drawn to OBGYN. I found it to be an incredibly very dynamic profession, part of medicine. Of course, delivering babies was overwhelmingly wonderful. And I will never forget the first baby that I delivered as a medical student. And of course, I darn near dropped it. Of course, I think that's the usual, comment that people make. But I remember just the exhilaration. Of course, I was a relatively young father at that point in time too. I had a couple children, and just that kind of when I delivered the baby, of course, it brought all that back, and so it was a
Right.
very emotional moment for me, delivering children as a practitioner, as a medical student, really. So, but I really thought really long and hard about becoming an OBGYN. I didn't do it for a couple reasons. I really don't want to work only with women. Sorry, I love you guys, but I kind of wanted to have the other side of the spectrum as well. And also is really demanding. You guys are
Yeah.
up a lot at night. You're in the hospital a lot. I just kind of curious of how you deal with that, because you got to be running on fumes sometimes.
Yeah, we run around a lot. I had a really crazy day on Tuesday, probably the craziest day I've had in decades, where I did 4 surgeries, delivered 5 babies, saw patients in the office. And the next day, which was yesterday, I came back and I did circumcisions for both of my babies that I had delivered the day prior. And the parents were like, how do you do it? How do you run back and forth? And you're here all the time. And that's really the hard part of it, is that it's very physically demanding. You're juggling a lot of balls at the same time. So you've got patients in the office waiting for you. You come over, you sometimes have a really stressful situation and you take care of that and you run back, and then you go home and then you run back, and you're sleeping in the middle of the night and you run back, and then you get up and do it all over again. So it's very physically demanding. I think you have to be the type of person that can handle that really high pace and have a lot of energy and not require a lot of sleep. It's exhilarating, but it's exhausting. So you have to be a special person who can take on that kind of commitment.
Yeah,
But there's
no,
a lot of amazing things about it, and your patients and the babies are why you do it. And that's why you keep doing it.
yeah, I mean, you've been doing this for a long time and you're still delivering kids. A lot of OBGYNs, as you know, kind of let
Retire.
go of the OB and focus on GYN
Right.
as they, move through their career. I think that, the obstetrics part, though, would be probably very difficult to give up, from just watching, you guys in action, and obviously being on the other side of the equation, looking at the baby, of course. Is that true?
Yeah, I mean, I do love OB. So it will be at some point in my life. I'm getting older. Physically, it's just very demanding. So I'll either really reduce the number of babies I deliver, or eventually not deliver babies. I'm not at that point yet. I don't feel ready to give that up.
Yeah.
But again, like I said, it's a great job. It's phenomenal. Like, there's nothing more special than bringing a baby into the world and helping people become a family. And the more I do it, and the more I feel like what a gift I have to be able to do this. And my goal is always to have a safe mom and safe baby. That's my number one goal. And if I can accomplish both of those things, then I feel like I've done my service. And I really believe it's a calling. And I pray, just like we did this morning, that I do the best that I can for my patients. It kind of makes me almost sad. I'm not sad, but emotional. But it's a phenomenal job, but very, very challenging.
Yeah. And I think you have to pace yourself. I mean, I certainly listen. There are days where I come home and I kind of go, "Wow, what a day!" When definitely during the winter times when we have a lot of illness in the community, and the kids are sick, and the phone calls are never ending, as
Right.
you probably have the same
Right.
phenomenon we do as pediatricians. And you kind of come home and you really do kind of flop down in your bed and you kind of go, wow, I'm beat.
Right.
And I mean, fortunately, I live near the hospital, so I have structured my life, and I'm sure you have too, where you're not driving an hour, you're not commuting an hour to get to the hospital.
Right.
Correct? Have you've had to kind of readjust where you live and all these different things because there's no other way you could do it.
Right. So we have to live close. Obviously, we would have loved to move up into a different area of LA, but due to what I do, you really need to be able to get to the hospital in 10 minutes. I mean, in reality, when there's an emergency. So you do have to live close. Again, I'm in a group practice, so we cover each other. So we're not taking calls every single night. Each doctor takes the calls for the others, but we do try to go in and do our delivery. So that reduces some of the onslaught of calls. And then take time. So time for exercise, time for doing things in your life, your family, taking a break, doing things that you love to keep you healthy, time for self-care for your brain to recover. So we all have a day off in the week where we're not seeing patients. So it's administrative time, catching up on charts and results. And I would still go in and do a delivery if I had a patient on my day off. But it does give me a time to kind of decompress and take a breath and get ready for the next week.
Yeah, yeah, we have to do that. I think that one of the things that certainly when you're in private practice, and I'm in private practice like you are, you're kind of there with your patients a little more intensely than
Mhm.
say if you were in a different kind of paradigm. And I find that to be obviously hard. At the same time, I find the relationships, and this is what you're talking about, the
Right.
relationships are very rich. And I, like you, Dr. Bohn, I have now generational, patients who certainly, I took care of his children are now coming back to me, and I'm seeing their children. I
Right.
can tell you, I just had a young woman today. I saw her son. It is so meaningful. It's like, wow, I love this, and you feel like you're very deeply part of the community, which is something that maybe I need more than other people. I don't know. You must feel that too.
Yeah, I think that those of us that choose private practice and not working like on the Kaiser model, where you just go and you do your shift and you go home. And the people we recruit in our practice have the same goal, is really wanting to establish those relationships with people and really caring for them for their entire life. And I mean, for pediatrics, it's a little bit different, but you get the kids who have their babies and they come back. But like I said, is that it is a commitment. You make a commitment to them. But it is something really special to know people in that way. And it's a lot easier to care for them because they really trust you. They trust the information that you're giving to them. And so I think that's the beauty of having that type of relationship. It does come at a cost and expense to you personally, but I think from giving the ultimate amount, the best care that I can give to somebody, I think that's the best way to achieve that.
Yeah. And I will just say parenthetically to those listening that Dr. Bohn has an amazing, amazing reputation in this community. Everybody who goes to her is in love with her. And and I think I've said that to you before, Yvonne, but I will tell you, you're obviously very beloved by the people who come to you, and that's to your credit. So a good job.
Thank you.
Okay, we're gonna take a 1 minute break here, and I'm gonna come right back, and we're gonna talk a little bit about some of the challenges that pregnancy and OBGYN kind of present. So friends, don't go away. You're listening today to the Hamilton Review, where kids and culture collide. We will continue our conversation with Dr. Yvonne Bohn in 1 minute.
The Hamilton Review podcast is brought to you by Hamilton Babies, 9 kid-friendly products designed for the little loves in your life. Find them at hamiltonbabies.com or amazon.com. Also consider Dr. Hamilton's recently published book, 7 Secrets of the Newborn, available at Barnes & Noble, your local independent bookstore, and amazon.com.
So friends, welcome back to the Hamilton Review. We are continuing our conversation with Dr. Yvonne Bohn, OBGYN, the private obstetrician gynecologist here in Santa Monica. Yvonne, I want to ask you about, there are women who are listening to the show right now who would like to have a baby, and they're looking ahead, and I'm just curious, in terms of the preparation, you kind of have to kind of do that before you actually get pregnant. So can you kind of walk us through your recommendations?
Sure. I think preconception is actually probably the most important part of ensuring a healthy pregnancy and healthy baby. So what we do recommend is that you do visit your OBGYN if you have the opportunity to before you get pregnant, several months before, to go over kind of where you stand in your overall health, to kind of prepare for it. So in pregnancy, one of the most important things is control of pre-existing diseases. So for example, if you're a diabetic, we want your glucose control to be actually tighter for 3 months before you conceive. So women who have good glucose control, low hemoglobin A1Cs, have much better outcomes than women who don't. Same goes for hypertension. If you have pre-existing hypertension, we want you to get your blood pressure in control before you try to conceive. Women who have hypertension have a higher risk of something called superimposed preeclampsia, which is preeclampsia on top of hypertension, which can be fatal to both the mother and the baby. The next is thyroid disease. So in conception, we actually want your thyroid function to be much tighter than when you're not pregnant. So in women who are wanting to conceive, I always check what's called the thyroid stimulating hormone. And we want that value to be less than 2. That optimizes your chances to become pregnant. Another thing we recommend looking for is a screening for recessive diseases. So now we have these very large panels that look at anywhere from up to 3 to 200 diseases, that if the mother and father both carry that disease, there is a 1 in 4 chance that the baby can be affected by that disease. And some of those diseases are very, very serious. They're metabolic diseases that have very poor life outcomes. So what we do with a mom is we screen the mom with a recessive panel to see if she carries a gene for recessive disease she doesn't know about. If she does carry that, then we can screen the father. And as long as both parents don't carry the same recessive disease, there really isn't an issue to going forward with conception. If there is a disease that both people carry that's very significant, then people now are moving to something called in vitro fertilization, where they get the mother's egg and the father's sperm and they fertilize an embryo. They freeze the embryo, and at a certain point in time, they go back and they biopsy the embryo to make sure the baby is not a carrier for that disease. And then the babies that do not carry that severe disease can be implanted back in the mother. Now, obviously, it's pretty rare that we do find a couple that both carry the same thing, but there are occasions where it happens. So that's a really, really important thing to do ahead of time. Most of the time, what's happening is couples are coming in already pregnant, and then we find that, and that can be quite serious. The next thing is weight.
So Yvonne, let me just real quickly. So do you do that screen on all of your patients? Because and is that becoming more of the standard of care in the community?
That is the standard of care.
Okay, so that is something that you get about 200 of these diseases, and certainly I can tell you that my observation out there is that the number of kids who are actually born with these kind of rare things is exceedingly even more rare than it was before. They've always been rare, but now they're even more rare because of this, what you guys are doing on the OB side of the equation there. Okay.
Yeah, so for example, the initial genetic screening was actually done for very few diseases, and part of that was because of the cost. So initially, we screened for cystic fibrosis.
Yep.
Because the carrier rate of that in the Caucasian population is very high. So in the Caucasian population, the carrier rate was 1 in 22. So the risk of having 2 Caucasian people with cystic fibrosis was quite high. So that started probably, my son is 21. So when I was pregnant with him, I was only screened for cystic fibrosis. Because genetic screening has gotten so much more affordable, we've made larger and larger panels. And another thing is that people's ethnicities are very mixed. So people really don't know, do they have some of Ashkenazi Jew in them that they're not aware of, which carries some of these more severe metabolic disorders. So the panels have gotten less expensive. And so we've also expanded who we give those panels to, because we don't know 100% what our ethnicity is. And it has helped to reduce some of these surprises. Now, even if a couple finds out that they both carry the disease and their baby carries the disease, when the baby's born, we can do the best things for them because we know ahead of time that they're facing this metabolic challenge. So some of it is just diet modifications. Other things are require much more intensive help for the babies. But we can also, even if you do nothing about the findings, we can also ensure that we give the baby the best opportunity when it's born to have all the medical intervention to help it.
Yeah. I mean, it's an incredible tool. It's a powerful thing. And
then we're talking about weight. Weight is really important. Body weight.
Body weight of the mother you're talking
Yes.
about now. Okay, so tell us about that.
So obviously, we want everybody to be at their most ideal body weight when they're pregnant, because the risk of pregnancy complications increase significantly if a mother is obese. So the risk of all of the bad pregnancy things, preeclampsia, diabetes, cesarean section, hemorrhage, all go up in a woman who has a BMI over 30. So we don't expect everybody to be perfect, but if you're planning to become pregnant, even losing 5% of your body weight can really improve your ultimate outcome. It also improves your fertility. Women who are overweight are less likely to ovulate consistently. So just a 5% reduction in body weight can improve your chances of ovulating and getting pregnant.
Yeah. Listen, I've seen women who are indeed obese, and they also have higher rates of C-section. I mean, you mentioned that, and also just the complications of trying to deliver a baby is much more difficult in that situation. What about vitamins? Do you recommend vitamins before conception?
Yes. So that's the next thing. So we do want all women to take folic acid. The minimum amount is 400 micrograms of folic acid, which is found in most vitamins, at least 3 months before conceiving. And that helps to prevent miscarriage, but it also helps to prevent something called a neural tube defect, which is problems with closure of the brain and spinal cord. So it also probably helps prevent midline defects such as cleft palate and omphalocele. So it's really important to have a prenatal or a multivitamin with 400 micrograms of folate pre-conception. The second thing that we're recommending now is, because we have an older population of patients, is that the other issue is that our egg quality declines as we age, and that puts us at higher risk for babies with chromosomal problems or miscarriage. And there is a supplement that's good for your heart called CoQ10, and you can buy that over the counter. And that's something that has been shown to improve egg quality. So if you're over the age of 35 and you're trying to conceive, that would be something I would add to my vitamin supplements to make sure that you're in the best health for conception. We check vitamin D levels when women are pregnant. So we like the vitamin D to be above 30. So another thing with overall helping with metabolic function of your body, it is good to take a vitamin D supplement if you're not getting adequate sunlight or your vitamin D level isn't normal.
Yeah. Are you routinely recommending vaccines? I mean, there are certain things like obviously rubella. You can talk about that if you want to, but also just, other vaccines. You want your patients to be up to date in all their vaccines, correct?
Right. So the one you recommend, what you just talked about, is rubella. Rubella is actually in a vaccine called MMR. It's mumps, measles, and rubella. And so we do really want you to be vaccinated and immune to specifically rubella, because if you get rubella during pregnancy and you're not immune, there can be serious birth defects from it. But also, not always, but intermittently throughout the years, there have been measles outbreaks. And measles is a highly infectious disease. So we really want you to be immune for measles. We don't see mumps that often, but for measles while you're pregnant. Now, you can do a blood test called an MMR, which is a titer that sees if you're immune to that before you try to get pregnant. If you're not, you should be vaccinated, and you have to wait 3 months before you try to conceive after getting your MMR vaccine. We do not give the MMR vaccine during pregnancy. It's one of the vaccines that's not okay with pregnancy. And so that's something you would want to check out ahead of time. The other is the flu vaccine. So the flu vaccine is safe in pregnancy. It can be given in any time of the pregnancy. So women who are pregnant, their immune system is not as strong. And so they're at higher risk for becoming ill from a viral infection. So the flu vaccine is a safe pregnancy vaccine. It's safe to give anytime during the pregnancy. So you can either get that pre-pregnancy, when the flu vaccine typically comes out in September, all the way up until April.
Yeah. Okay, so the MMR you do not give during pregnancy, but you obviously are checking titers on the mother to see if they actually get rubella during their pregnancy. That would be a concern. When do you recommend getting the MMR vaccine? Can you get it immediately after delivery?
They'll actually give it to the mom postpartum. So in the postpartum, before you're discharged from the hospital, because we have the MMR titer on file, they'll offer the mother a vaccine before she goes home.
Yeah, which is brilliant. And those vaccines are good for many, many years, right?
Yeah. The other vaccine that we give in pregnancy, even if mother has received it in a prior pregnancy, is the whooping cough vaccine. So it's called Tdap, which is tetanus, diphtheria, and pertussis. And the tetanus part of it lasts for 10 years. We think that the whooping cough part of it probably doesn't last as long. So what we do for every mom in the 3rd trimester, we do give a booster of Tdap so that the baby does get some immunity from the mother through the placenta, and it covers the baby for the first 2 months of life until the baby can get vaccinated and start to build immunity on its own. And Bob, you can tell us more about whooping cough. And it's a really serious illness for newborn babies.
It sure is. I mean, so this is important. This is a relatively new development, giving the Tdap. And so the Tdap does include a pertussis element in that vaccine. And by basically giving it to the mother makes what we call IgG antibodies, which are transferred across the placenta. So the beautiful thing is the mothers are giving their newborn babies all sorts of immune globulins through their placenta and actually through their colostrum and milk as well. But those IgG antibodies, which are resident in the newborn baby, essentially protect that baby during a very fragile time in their life, the first 2 months of life. And you can actually begin to give the Tdap, our equivalent of it, we call it DTaP in pediatrics, but we give that actually at a month and a half of age in our practice. But basically, that fragile period of time when kids are a little more susceptible to infections and issues, that particular bug, pertussis, the kids are protected against. And by the way, just parenthetically, pertussis is a bad infection in newborns. These poor kids can't breathe. And historically, in times gone by, pertussis actually caused the demise of really a lot of kids. It was a feared infection. Thankfully, we now have the vaccine against it. Okay, so this is all good. Any other thoughts about if you're going to get pregnant?
Let me see.
Get in shape. You got to get in shape because
shape. Exercise. Oh, one thing. Let's talk about exercise. I'm a big advocate for exercise.
Yeah.
If you exercise before pregnancy, let's say you develop a great exercise routine, whether it's running, whether it's doing CrossFit, spinning, yoga, you can continue to do that exercise during pregnancy. You will modify your activity as you get larger. And there's certain activities that are harder to do when your abdomen gets bigger, or your baby gets bigger. But exercising ahead of time, preparing your body for a good exercise routine, that's something you can carry out while you're pregnant. If you don't exercise before you're pregnant and then you get pregnant, now that's not a time to start spinning in CrossFit. Okay. So you have to do more. If you've never really exercised, then you're going to do much more moderate, gentler exercise, such as walking, stretching. But I really advocate exercise. You really want to get your body in the best shape physically, as far as medically, emotionally, so that you can be, the best that you can be for your baby. Yeah. I don't know what else to say about that. Obviously,
no, my wife, Leslie, as you know, we've had 6 kids, and her favorite one was swimming. She was a big swimmer. And I think that one, by the way, you can keep that going till the very end, because you're pretty buoyant.
Yep. And with swimming, you, especially in the 3rd trimester, when you get swollen, the water helps reduce edema, the cold water. So that's another thing. When I have patients who are really swollen, I said, get in a pool. It'll help reduce some of your swelling. And then when you're in the water, you don't really feel pregnant like you are when you're walking around out of the water.
Yeah, no, exactly. That was a good thing for us to do. Okay, we're gonna finish in one. I have one last question for you, then we're gonna close it down. I have patients in my practice who want or have done home births. Mm-hmm. I'm curious about your thoughts about this. I generally recommend not doing it. And if they do end up being, this is their desire, I do recommend that they have a very low threshold for anything that goes wrong. From an OB/GYN perspective, what are your thoughts?
Well, as a practicing OBGYN, I do not advocate home birth. And actually, the American College of OBGYN also does not advocate home birth, which is kind of like the people who we turn to for medical advice and education. And the reason for that is that when birth is good and it goes well, it's amazing. So if we had a crystal ball and we knew you were at home and it's your 2nd baby and you were going to have a really easy birth, that would be fantastic. But we don't have that. And being a practicing OBGYN and doing this for 29 years, things happen fast. And you only have so much time where you either can help the baby and prevent brain damage with an expedited delivery, or if a mother hemorrhages. Postpartum hemorrhage is scary. Postpartum hemorrhage happens very quickly. And many times you need to be in a hospital with support to help stop that bleeding and support the mother while we get her through it. So I have to say, in an event where the pregnant, you're in labor and it happens so quick and the baby comes out at home, that's unavoidable. You're driving, 3rd baby. I've had patients deliver on the 405 freeway. Again, those things are unavoidable. Those are things that we cannot control. But if you're planning for that at home, unless you live across the street from the hospital, especially if you live in a place like Los Angeles. I had a patient who lived in Malibu who thought that they could have a private ambulance by their house and get to the hospital fast enough. You can't. The PCH on a Sunday afternoon could take you an hour and a half to go 5 miles. So you just don't have the access to get to a safe place fast enough. Now, there was a lot of ideas of having birthing centers next to hospitals that provided a home environment for mothers where they could be quickly expedited to the hospital. That would make a lot more sense and would give people the sensation that they're somewhat in a home environment, but have access to safe care very quickly. So like I said, I just don't think you can predict it. I think if there's an emergency, you may not be able to get there on time to save either the mother or the baby.
Okay, so there's the answer, and I concur with that answer. I really do, because I've seen things happen, and they do happen very quickly, and they're scary. And we as doctors, we get scared, and when we have these things happen in front of us. So, Okay, well, Dr. Bohn, we're going to end it there. You have been a tremendous guest. Thank you for taking the time to be here today on the Hamilton Review. And I really appreciated talking to you.
Of course. Thank you.
And
So good to
friends,
see you. Thanks
thank
for
you
having
so
me.
much. You're welcome. And friends, until next time, be safe. Bye-bye.
You have been listening to the Hamilton Review, where kids and culture collide. Thank you for allowing us to be a part of your day. Tune in again next week on Apple Podcast. Rate and comment and tell a friend.